it may be a different color also, that is liquid, and another that is foam type. You can find that is a kind of foam, and you have to apply on your hand. And why? What is the purpose? Purpose, it is to clean contaminated hands. Means when your hand it is contaminated, see my hand it is clean, right? Visibly it is not soiled. If it is visibly not soiled, that time you have to apply hand rub. Okay, if your hand it is visibly soiled, that time you have to apply hand wash. Okay, and what I told previously, that to prevent cross and nosocomial infection. Cross means one patient to another patient. One patient has a different microbial issue, and that has to transfer or contaminate to another person, or it may be vice versa, from the patient to healthcare person also, to physician also, to nurse also. To prevent that kind of infection, we have to go through hand wash and mainly hand hygiene, hand wash and hand rub. WHO and WHO has defined that 5 points. In these 5 points, when you are in the hospital environment, you have to maintain this 5 points before touching a patient. Before touching a patient, you have to maintain your hand hygiene. Okay, and before a procedure, may be you are fitting a catheter or a injection or anything, or you are taking the blood pressure, before that also. Okay, and after a procedure, means after you are taking a blood pressure, before the taking a the blood pressure, you have to go through that hand washing or hand rub or hand hygiene, you may say. And after that also you have to perform the same thing, because from that patient, whatever disease it is there, it may be any bacterial or fungal disease or viral disease, it may cross infect to you or to other person also, or other patient, or to the other patient also. And after touching a patient, if you are touching a patient to for any care or any medication purpose, you are touching a patient, that time also you have to perform hand hygiene. And last, after touching a patient, surroundings, means you are touching bed rails of a patient, bed, that time also after that touching, you have to maintain your hand hygiene. And I told that hand washing, that medical hand washing or normal hand washing, it is by soap and water you have to use. But when you are going for antiseptic hand wash or any surgical hand wash, that time you have to use soap with antiseptic agent will be there. And alcohol based hand rub, in the alcohol based hand rub, that is maybe 70% alcohol or isopropyl alcohol, or you may say isopropanol, you have to use. Students, can you say why you are using 70% alcohol? Why it is not absolute alcohol or 99.99% alcohol? Any idea? Why 70% alcohol? Any idea? 70% alcohol means 70% alcohol and 70% absolute alcohol and 30% water, means sterile distilled water. Okay, and this percentage, if it is a absolute alcohol, it will evaporate easily, right? But 30% water is there. When you are using 70% alcohol, it will stay more time on your hand, right? And if it is staying more time on your hand, it will be more permeable to the microorganism or inside into the microorganism cell. And that that alcohol will denature all the protein. Protein means functional and structural. You have studied all the proteins, it will denature. And because the protein is getting denatured, bacteria will die. or the microorganism will die. That is why 70% alcohol we have to use. Okay. And before going to hand hygiene, you have to take care about your hand, means nails. If your nail should not be nail tip should not be more than 0.6 centimeter. Okay, and you have to diligently you have to take care, means when you are cleaning your hands, your nail and underside of the nail, you have to take care. Okay, you should not wear any rings when you are going for any aseptic condition or any means to maintain your hand hygiene. You need to remove your rings. Okay, hand creams, if you are using any cream, that may be effect to clean your hand, because applying soap or any alcohol based hand rub, it may have some adverse event, because that cream, it is also contain some chemicals, and you are applying soap with antiseptic soap or any 70% alcohol, that is also a chemical, and maybe some chemical reaction, and you may get some hand rash or anything. That is why you have to take care about your hand creams, means you should not use any cream. Okay, and if you have any cuts, that time you need to take care about that, means you have to wear gloves properly. If it is means more than if you are thinking that you can't apply gloves, then you should not go for that process. Okay, then skin problems, it's very common, and some fungal disease may be there on the skin. That's why some when you will go through that main course of microbiology, that time you could understand that fungal disease and all. That time means if you have some skin disease, that skin disease, it may spread to a freshly individual, means a patient to a patient, or from a patient to you. That also you have to take care. Okay, and WHO has defined that particular process for hand wash, and the time, it is total time to washing your hand, it is 40 to 60 seconds. 40 to 60 seconds you have to maintain, or within this you have to make it. But when you are going for surgical hand wash, that hand wash, it is around 3 to 5 minutes. Okay, and the same thing for hand rub, you have to make it for or takes only 20 to 30 seconds. And what is the process, how you have to do everything, I will go elaborately one by one, and total this 7th step you have to follow. That 7th step you have to follow. Step 1, before you are washing your hand, obviously you should apply some water, and you will apply soap on your, or hand wash liquid soap on your hand, and you have then this 7th step I will go one by one, and you have to take some preparation, because some adequate amount of water flow should be there, means proper water flow, if it is not there, that washing your hand, it will affect your washing your hand, means soap maybe will be there, or maybe visible soil it may present on after washing also it may present. That's why adequate amount of water flow should be there, and the particularly the tap should be elbow knob. Okay, elbow knob tap will be there. If it is not there, then you have to use your that after cleaning, or you are use a single use tissue, paper tissue. With that paper tissue you have to close the knob. Okay. First step, after applying soap on your hand, you have to rub hands palm to palm. Palm to palm you have to rub, means palm to palm you have to rub, like this you have to rub, means how we are washing your hand. Palm to palm we have to rub, because to spread all the soap on your hand. Okay. Then rub back to each hand with palm of other hand, means that like this you have to apply, like this you have to apply, okay, and vice versa, means left and right, vice versa you have to apply it, okay. Then interlacing condition, means this is called interlacing, means in between fingers, interlacing condition you have to wash it, means you have to rub or you have to go through. Then interlocking, then it will come interlocking. Interlocking means this condition to clean nail, underside of the nail, and this portion you have to clean it. Then in the rotational movement of thumb, you have to make a rotational movement clockwise and or anti-clockwise rotational movement of your thumb, means to clean this portion, right, and the same vice versa with left to right, right to left, okay. Then you have to clean that fingertip and these portions, these linings are there, okay. It will hard to remove the soil, that is why you have to clean like this, clockwise or anti-clockwise you have to clean it. Then you have to that wrist rotation, you have to wash the wrist in the rotation condition like this, and after that you have to wash your hand in adequate amount of water flow, and you have to close the tap with elbow. Elbow knob will be there like this. In the hospital environment you can find that elbow knob is there in the tap. If it is not there, if it is not available, then after that you are using a tissue to absorb the water, excess water, to dry your hand. With the tissue you have to close the knob, okay. And for the surgical hand washing, the same thing you have to do, but up to elbow you have to clean. Up to here, normal or medical hand washing, you are washing your hand up to wrist, right? And for surgical hand washing, you have to wash up to elbow, okay? And antiseptic soap you have to use. After that, you have to and one skin rub you have to use, or skin scrubber you have to use, that is a kind of sponge you have to use to clean properly your hand. These are the areas WHO has defined, means that red color, it is most frequently missed when you are cleaning your hand. This red color mark is there. We are most frequently we are missing these parts. Then that brown color, it is frequently missed, and that yellow color, it is less frequently missed. You have to take care when you are washing your hand. All those things means that 7th step covered all this area to clean, right. Then we are coming for alcohol based hand rub. Everybody nowadays, it is very much we are using that alcohol based hand rub, and in the hospital environment or in the home also we are using, because after that COVID and the period of COVID also we have used. And because why we will go for hand rub, because means anywhere we can carry it, it is portable first of all, right. Then if it is not your hand, it is not visibly soiled, that time you can apply, means one patient to another patient, when you are visiting one patient to another patient, or any aseptic condition you are maintaining, that time one to another you have to maintain that hand rub. Before entering the ward or hospital environment, you have to hand rub, and when you are coming out from the wards or hospital environment, also you have to maintain hand rub, or you have to perform hand rub. And it is also take less time. Water we are not applying, means water it is not available and your hand it is not visibly soiled, that time you can apply hand rub, alcohol based hand rub. And where we have to place or where we can find all these things, that is at every bed means ICU, burn unit or ER means emergency room, and at every ward entrance, ward trolley, that trolley is there in the ward, right, that there also it should be there, and entrance to every room on every incubator, that hand rub should be there, and because that anywhere you can apply hand rub, because for one process to another process when you will go, you have to apply hand rub. And that I told that that is gel rinse, and foam rinse means that is fully liquid, that yellow blue color liquid kind of thing we are getting, right. This is that blue color, it is coming from the edible blue color. They are mixing the blue color to identify particularly, that is why that blue color, and the foam also will be there. And when you have to perform, after removing gloves or before putting the gloves also you have to perform, or after after hand washing also you can perform hand rub. And now some new products are there for hand hygiene, that is chlorhexidine gluconate 1% with 61% alcohol. It is more effective than 70% alcohol also, that is why this kind of thing it is also available in the market, and it is the new thing, and also it will kill 99% of the germs on hand, that is why also you can use. And in the hospital environment you can find from the Department of Microbiology, we have displayed this kind of poster that how to wash your hand. It is in Bengali language, because that local language it is Bengali, that is why we have mentioned it is in Bengali language to easily to communicate to the other person who is not from the medical background. They have to perform, because a patient any patient family from the any member from the patient family, they are coming to visit in the hospital, they have to also perform this hand rub or maybe hand wash also. That is why this kind of it is taken from the WHO site only, and that hand rub also we have made from the Department of Microbiology, and that poster it is also available in the hospital environment. And before the end of this hand hygiene, I like to mention that bacteria and virus can cause illness and even death, but every bacteria it will not harmful. It is not harmful, that also you have to remember. And where you means no matter where you are, no matter what you do, wash your hands. You have to wash your hand to keep your health means from the nosocomial infection and other to keep it away. You have to go through hand wash or you have to maintain your hand hygiene. Now I will come to PPE. PPE means personal protective equipment. The intended purpose of personal protective equipment, it is to prevent nosocomial infection or to prevent cross infection or to prevent the exposure of any body fluid from the patient or any other hospital environment. Okay, and that hair cover or cap, eyewear or goggles or face shield we have to use, mask, ground, apron, gloves, shoe covers. These are all different types of or kinds of PPE that you have to use in the hospital environment or in the surgical process or any aseptic condition you are doing, or in the lab also you have to maintain all these things. Then when that PPE it will come, that thing is donning and doffing. Donning and doffing means you have to how to wear PPE and how to remove PPE. That is also mentioned by CDC. Okay, and at first you have to wear when you are wearing the all the PPE, that time you have to wear ground at first, then you have to wear mask then goggles or face shield, then gloves. At the end, you have to wear gloves. Okay, before wearing gloves, you can use hand rub also. And when you are removing, at first you have to remove gloves. And how to remove gloves? You have to use like this, and you have to remove, means inside out. You have to keep the gloves inside out. Okay, like that you have to remove. Then you have to remove goggles or face shield. Then you have to remove ground, then mask or respirator you are using. Then you have to wash your hand, or you have to go through hand rub. One thing you have to remember, when you are using mask, that surgical mask, it is for 4 to 5 hours. At a time you can use it, and it is for single use, and before that also you can remove if it is visibly soiled or if it is wet, means you are keeping it on your mouth, right? It may get wet also, that time you have to remove it. But when you are using N95 gloves, mask, that time you have to remember that it is for only for 8 hours, and single use, you can't wash it, or it can't protect the oil aerosols like that, and only it can protect airborne particles, that is up to 95%. Okay. And sometimes you can reuse all the things ground if you want to reuse. For that, a single patient only you have to use, and you have to keep inside out, you have to hang it inside out, and for the next patient you can use a different or new PP. Okay, new set of PP. Any questions or anything? Okay, thank you.
Interpleural pressure, interalveolar pressure, transthoracic pressure, transpulmonary pressure, one type of transpulmonary pressure. তার মধ্যে কি transpulmonary pressure. Transpulmonary pressure means formula কি intra-alveolar pressure minus interpleural pressure. Good. And what is the basic rule of this transmural pressure and intra-alveolar pressure? মনে করো একটা interpleural pressure is -5. Then what should be the transpulmonary pressure? +5. Good. That means only the sign will be different, value will be same. That's a big point. So we have to expand your lung so that our perfusions, the ventilations go adequate. তাহলে আমাকে যদি ভালো করে ventilation perfusions করতে হয়, then we have to expand our lung. এই expansibility, stretchability, আর কি বলবো, distensibility, that is called কি stretchability of lungs is equal to compliance নয়, compliance, right? So that is called compliance. C equal to, what does it mean? Suppose I am giving a clue. A patient age suppose 62, male patient with history of smoking, smoke করছে for years. Now come at year, তোরা যখন কাজ করছিস as a intern, come with increased respiratory rate, is high respiratory rate, dyspnea, along with pulse is very high, maybe or plus minus cyanosis may be present, plus minus. And the patient's relative is complaining that in the last 1 to 2 years, this type of complaint is coming off and on. বারবার আসছে যাচ্ছে. So such symptom, it off and on basis. So what does it mean in your primary level of thinking? The patient তাহলে কি রকম conditions হতে পারে? patients having the low, and then we go for a function test, and that is showing the altered different values, specifically FVC by FEV1 or both is altering. I am not going details into the parts, but spirometry is altered. Then what kind of patients is that? Key problem hoche, and the sound of the patient is like that. Emergency te achiস, respiratory distress niye elo, patient নিঃশ্বাস নিচ্ছে খুব সুন্দর. That means inhaling, but when it is expiration, it is longer. That is such type of. That means expiration is prolonged. That means indirectly it implies that some difficulty of expiration or is difficulty of air out. বাইরে বের করতে তার প্রবলেম হচ্ছে. He has a difficulty of air out. That means expiration phase is high. Inspiratory phase is short. If I is to E ratio, that is decreasing. Why? Because E is increasing. So I is to E ratio is altering. Now such type of patients, when you are dealing with the patients having prolonged expiration, that may be any cause. I don't know, I never utter any diagnosis. Always think about the obstructive disease. That means some obstruction is going on. So remember this, the take-home message is that whenever is difficulty in air out, আমাকে যখন অক্সিজেন, কার্বন ডাইঅক্সাইড যে কোনো যাই কিছু হোক, আমার বেরোতে কষ্ট হচ্ছে, অক্সিজেন তো নেবে, কার্বন ডাইঅক্সাইড বের করতে কষ্ট হচ্ছে, বা একটা এয়ার ফ্লোর প্রবলেম হচ্ছে, and I/E ratio is increasing the inspiratory phase, that means obstruction is there. No query about that. Obstruction একটা আছে. So what are the diseases? What are those diseases of the obstructive diseases? Means emphysema, okay, no problem. Emphysema, I am written in short, that is emphysema, number 1. Number 2, bronchial asthma. Why bronchial asthma is called bronchial asthma, not bronchiolar asthma? Any idea of that? Bronchial asthma ke কেন আমরা bronchiolar বলতে পারি? Bronchioles problems আছে. That's also airways problem difficulty. Then why it is called bronchial? If time permits, I can explain that. So next, obstructive, yes. Bronchitis, that may be chronic, always not acute, because acute bronchitis is mostly viral. Now I am dealing some serious patients is viral bronchitis, stachytis is just going on. So that is called chronic bronchitis. Then bronchiectasis, very good. So these are all, always remember, bronchiectasis. Always remember, this is the obstruction. What is happening here? Is difficulty to air out. Difficulty in air out. আমাকে বের করতে কষ্ট হচ্ছে, ইনহেলেশনের প্রবলেম নেই. Now, if it is difficulty in নিতেই কষ্ট হচ্ছে, যখন বেরোচ্ছে তখন সুন্দর বেরোচ্ছে, যখন নিচ্ছে তখন this is happening. That means I/E ratio is increasing. Inspiration is in very short. Taking the breathing. So means problem is in. Oxygen নিতে কষ্ট হচ্ছে. That means restrictions. Remember always, any restrictive disease, any restrictive in lungs, that may be heart, always feeling problem. What problem? What problem? Feeling problem. Feel. So feel of air, that may be feel of blood. Everything can problem in feeling. So restrictive is always problem in filling. Filling will be less. Filling will be less. In case of pulmonary system, we have some restrictive pulmonary disease. Just like we go for just emphysema, bronchial asthma, chronic bronchitis. A chronic bronchitis and this emphysema is together called COPD. That is chronic obstructive pulmonary disease. COPD তোরা আরামসে পাবি এখানে প্রতিদিন পাবি 4-5টা করে COPD বেসে. Not always that you can get the smoking history. You can get also non-smoker also can come with this. With age also that can happen. COPD can happen in older ages also. Because I'm coming later what is happening here. And one other is a restrictive. Restrictive is problem in air in. So air in problem. And here these are all out problem. করতে পারছে না and here in করতে পারছে না. This is the basic difference. কোনদিন ভুল হবে না তাহলে. So whenever you are dealing with any graph that is oftenly daily by every semester and every prof you can get the graphs of spirometry, then these things will keep in mind. That whenever we are dealing in restrictive, that means some filling problem is there. And whenever you come in obstructive diseases, I am not going details now in this class because there are lots of value is there. FEV1, FEV1 AC, that's the ratio, tidal volume capacity. We'll take if next class, the class after that, we can explain of the capacities and volumes. So they're different. But gross idea is that any patients having with respiratory distress, you have to first came across if it is directly related to the respiratory problem, then you have to divide it into the two parts, whether patients having restrictive cause or whether having obstructive cause. In the clinical sign is that in case of prolonged expiration, the difficulty for the expirations, that means obstructions is there. That may be foreign body also. But in case of restrictive, that means in problem is there. নিঃশ্বাস নিতেই পারছে না. তাহলে এটাকে একটু ওই তোরা পড়িস নিশ্চয়ই পড়িস তোরা সক্স মানে মজা পড়িস তো নাকি সক্স পড়িস তাহলে এর ক্ষেত্রে এরকম একটা সক্স আঁকি এটা কি রকম টাইপের সক্স হলো একটু ঢিলা ঢালা অনেক ধরে পড়ছিস অনেক ধরে স্মোক করছিস খেতে 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 কি হচ্ছে ইলাস্টেজ এনজাইম ইলাস্টিন শেষ তাহলে রিকয়েলিং প্রপার্টি উইল বি ডিমিনিশড তাহলে এখানে কি হচ্ছে ঢুকে যাবে এয়ার ঢুকে যাবে তুই ভালো করে মজাটা পড়তে পারবি বাট কি হবে জিনিসটা রিকয়েল হতে পারবে না সো রিকয়েলিং অর ইলাস্টিসিটি ইজ এ প্রবলেম নাও রিমেম্বার অলওয়েজ opposite of compliance is two things. One is elasticity, another is surface tension. মানে surface tension বাড়লে compliance কমবে তেমনি surface tension যদি বেড়ে যায় এই surface tension যদি কমে যায় তাহলে compliance বেড়ে যায় উল্টো elasticity সেম থিং তাহলে compliance কে যদি এক্সপ্লেন করতে হয় তাহলে পুরনো ঢলঢলে মজার কথা মনে রাখতে হবে that is happening here কি জিনিসটা হচ্ছে you can expand your socks you can expand your lung but recoiling property is almost nil that's why recoiling property absent that is why our out problem is problem air cannot be out that is the recoil how air is out because of elasticity property of the elastic recoil property of the lung তাহলে লাংসের মধ্যে আমাদের কি কি প্রপার্টি আছে একটা দিকে ঠেলবে আবার দিকে নিয়ে আসবে ছবিটা এঁকেছিলাম না ছবিটা কেমন আঁকা ছিল যদি লাংসকে এক্সপ্যান্ড করতে হয় দেন হোয়াট উইল হ্যাপেন লাংসের মধ্যে এইদিকে একটা ফোর্স কাজ করে এখানে যদি আমার রিবস হয় and then এইদিকে একটা কাজ করে that's why the pleural space or pleural pressure is always negative right so lungs is going inward and that is also inward, and lungs also can expand in this way so that air can out. So how we can dealing that? তাহলে নিশ্চয়ই আমার ব্যালেন্স আছে. That's why we are taking breath and no respiratory problem. But that patients, bronchial asthma, chronic bronchitis, emphysema, COPD, all have some outflow problem is there. And that's why that is the old socks. That is like a old socks. Air can entry, but cannot recoil. তুমি এখানে ছোট করতে পারবে না. But in case of restrictive disease, stiff. That means what? It cannot extend, but easily recoil. It cannot extend or expand, but it can easily recoil. কি হবে? নতুন মোজা কিনলি, নিয়ে খানি ওয়াশিং মেশিনে আচ্ছা করে দিলি, গেল ওয়াশিং মেশিনে দিলি, আরো সুইং করে গেল. So what is happening here? In case of restrictive disease, collagen fibers or fibrosis is happening here. It is a big issue. Restrictive, not only that, always only the fibrosis, not know that, but remember, whenever you are dealing any restrictive disease or thinking respiratory disease, any disease having says oasis is always restrictive disease, like pneumoconiosis, asbestosis, silicosis, pulmonary fibrosis, all are osis is restrictive disease, right? So in this way you have to study, otherwise memory করতে গেলে পরীক্ষার টেবিলে যা তো দাদারা করছে, দিদিরা করছে, সব ভুলভাল বলতে পারছে না. রেস্ট্রিক্টিভ কি অবস্ট্রাকটিভ বলছে, অবস্ট্রাকটিভ রেস্ট্রিক্টিভ বলছে. So concept is very clear from now onwards. That is, whenever a patient you are suspecting obstructive pulmonary disease or obstruction is going on, always remember that is old socks. That means it can expand but does not recoil. Number one. Number two, compliance is always high. Why compliance is high? Now, compliance is equal to delta V by delta P. That means unit change of pressure. What is the volume change? তো দাদারা বলতেই পারেনি, কোন স্টুডেন্ট ফর্মুলাটাই বলতে পারেনি. So compliance equal to delta V by delta P means volume change and pressure change, unit change of pressure. This is happening. So compliance is inversely proportional to the pressure change and is directly proportional to the volume, right? So now you come to these socks. That is emphysematous sock. You can say COPD socks. You can say bronchial asthma. Anything, anywhere this is type of lungs is there where it can expand easily. It can expand when volume is increasing. Volume is increasing. So delta V is increasing much more than the decrease of pressure. Pressure তো কমবে অবশ্যই. Boyle's law তো আছে. The Boyle's law কি বলছে? Pressure is inversely proportional to the pressure is inversely proportional to the volume, or volume inversely proportional to the pressure. But volume is increasing much more, so that compliance will be increased. So compliance will increase means elasticity will decrease. বললাম ওরা দুজন দুদিকে ছোটে, একদিকে compliance তো একদিকে elasticity. So elastic recoil or elasticity decreasing in case of obstructive pulmonary disease. But in case of pulmonary disease, what is happening? কোথায় গেল? এই যে ইনি এখানে স্টিফ হয়ে বসে আছে, স্টিফার, স্টিফ লাং, fibrosis, silicosis, pneumoconiosis. You can utter the all over the occupational hazards like the silicosis, asbestosis. These are all the term is called pneumoconiosis. All the written in your book. Pneumoconiosis. যাই থাকুক না কেন, oasis is always restrictive. Pulmonary fibrosis, you can say cyst means restrictive, and that is a problem of in. নিতে পারছি না, out problem obstructive. পুরনো socks, old socks. Restrictive, shrink socks with shrinkage, ছোট হয়ে গেছে. তাহলে কি হবে এখানে? এক্সপ্যান্ড হতে পারবে না, expand হতে পারছে না, but he easily can elastic recoil is positive. So compliance will be less or more. Compliance will be less or more. Volume তো বাড়ছে না, তাহলে ভলিউম যদি কমে তাহলে less. And elastic recoil more or less? More, because compliance is opposite of the surface tension as well as elastic recoil. So compliance is means the stretchability, distensibility and also extensibility. লাংসটাকে বড় করা, এটাই কমপ্লায়েন্স। এটা না করলে কি হবে না? ভেন্টিলেশন হবে না। ভেন্টিলেশন না হলে পারফিউশনস কোনো গল্পই নেই, then we will all die. So compliance is very much important. Clinically, this is very much important than any other types. In the pulmonary system, this obstructive pulmonary disease and restrictive pulmonary disease, এই দুটো যদি ভালো করে বুঝিস তাহলে মোটামুটি 60% পেশেন্টকে ডিল করতে পারবি উইথ দ্য এমনি ওপিডিতে তোর চেম্বারে বসে বসেই, if you understand this properly and diagnose properly, because the treatment modality is different for both for those. So if you suspect any bronchial asthma and more than 6 years of age, then we always suspect যদি করি তাহলে pulmonary function test we do for that. But if it is less than 10, less than 6 years age, then we do FeNO. FeNO testing is nowadays coming, that 2 years, 3 years child, we can do the FeNO. FeNO testing, that is also easy, and that shows the graph, and patients having some reactive airway disease. What do you mean by reactive airway disease? Now, this bronchial asthma is nowadays is going obsolete, and that is replaced by a reactive airway disease. Reactive airway disease of your any senior prescription is like that a reactive airway disease. Nowadays we are writing that reactive airway disease, that means suffering from hyperactivity or hypersensitivity of the airways, and that's why it is called bronchial asthma. Bronchial asthma, not bronchiolar asthma. Bronchitis chronic and emphysema is called COPD. Emphysema and chronic bronchitis is COPD. Very, very common in this area. Anywhere you can see. আমরা মেডিসিনে যখন ইন্টার্নশিপ করেছি সিওপিডি দেখে দেখে হাত ধরে গেছে। But whenever you are dealing with any COPD patient, the pathophysiology is that is the old socks. It can expand but does not air come out. I am repeatedly saying in this word because this is the main clue, and this can be helpful for your diagnosis in spirometry, that the patient having the cough is of restrictive disease or is of obstructive disease. তোদেরকে শুধু এইটুকু বলতে হবে, তার জন্য এটা শিখতে হবে, নাহলে হবে না। Spirometry will come, but anyhow, any confusion up to this, because this is a very interesting and very easy also. If you remember the character of socks, old socks and some stiff and কি বলবো elastic হয় এরকম socks, these cannot expand, that means volumes cannot be increased, delta V not increased, compliance less. So in case of restrictive pulmonary disease or any oasis, there is কি হবে? Compliance less, elasticity more. When elasticity and compliance are inversely proportional, তাহলে এইটা আগে খাতার মধ্যে লিখে নে, এইগুলো কোথাও থাকবে না। Compliance is inversely proportional to elasticity, and as well as is also inversely proportional to surface tension. বোঝা যাচ্ছে না? মাথা দিয়ে শুনছিস, বেরিয়ে যাচ্ছিস, খেয়ে দিয়ে এসছিস তো এখন ঘুম বাবা, আমি এখন ভাবছি ঘুমিয়ে যাবো, ভালো লাগছে না। So spirometry is always done after the 6 years of age. After the 6 years of age, that is done the spirometry to differentiate whether it is obstructive or it is restrictive, as well as when you are giving a treatment or using some inhalers, in case of some reactive airway disease or bronchial asthma, then you have to prognostic value of spirometry is there. যে আমি যখন একটা ইনহেলার দিচ্ছি ব্রঙ্কোডাইলেশন দিচ্ছি তখন আমার আউটফ্লো ইনক্রিজ হচ্ছে নাকি, ইট ডেফিনেটলি হয়, and that's why spirometry always done with some bronchodilator spray, that means some inhaler with the bronchodilator. তোর তুই যদি করতেও যাস, তোর কাছে ইনহেলার ইউজ যদি নাও করিস, তোর ডক্টর যদি নাও দিয়ে থাকে, ওদের কাছে ইনহেলারে bronchodilator থাকবে. So first of all you without bronchodilator, then with bronchodilator, and that is the changes. The changes was obvious if the patient is suffering from reactive airway disease and also treatment failure is going on. এই একটা দুদিন আগে একটা পেশেন্ট এসেছিল, স্যার আপনি ইনহেলার দিয়েছেন, ইনহেলার আমার বাচ্চা ভালো হচ্ছে না, 2 মাস হয়ে গেছে একদম ভালো হচ্ছে না. ইটস ভেরি ব্যাড কমপ্লেন ফর মি, ইটস ভেরি ব্যাড কমপ্লেন ফর মি. তার মানে এই পেশেন্টটা তৃতীয়বার আমার কাছে আসবে না ইফ আই এম নট কনভিন্সড দ্যাট what was my plan on that drive. After doing everything, yes, spirometry it is showing that is a deterioration of the problem. That is a deterioration of the problem even after I steroid inhalations given. So what was the problem? It's my problem of diagnosis. That was not the problem. The problem was the technique they were using their inhaler is totally wrong. They are using key directly মুখে নিয়ে ফাস্ট করে দুটো দিচ্ছে টিপে দিচ্ছে. They are not using at all spacers. That means increasing the dead space. Now the question is come in your mind, what do you mean by said dead space? That is important. So every aspect of clinical scenario is important. So what do you mean by dead space? Any idea of dead space? Any idea? Conducting areas, very good. So whenever you are taking any sorts of inhalations, the conducting path, the trachea and up to the respiratory segment or respiratory unit, which are not participating in case of gas exchange, that is called the dead space. And dead space idea is very important for mechanical ventilation also. Our junior, our কিছু senior is using mechanical ventilator, but it is using unfortunately without any knowledge of the minute volume, without any knowledge about the is dead space is very important. I'm not going details into that part, but what do you mean by dead space? One is anatomical dead space, another is a physiological dead space. Now anatomical dead space already described, that is a conducting part of the conducting respiratory unit up to the respiratory unit. What do you mean by respiratory unit? Anyone? What do you mean by respiratory unit? Alveoli and alveolar duct, alveolar sac. These are the respiratory unit that helps into the gaseous exchange, and that is a gaseous exchange which is important for all throughout the classes. এই যে এত ক্লাস হচ্ছে এত কিছু হচ্ছে কি, that is up to depends upon the gaseous exchange. কার্বন ডাইঅক্সাইড ছেড়ে যাবে, অক্সিজেন আমার সামনে আসবে, oxygen আমার ব্লাডে আসবে, and that goes to the different cells and this. So exchange, gaseous exchange, alveolar exchange, gaseous alveolar exchange, all are similar terms. So for the dead space there should not be any kind of gaseous exchange property. But physiologic alveoli is there, but anyhow any disease conditions, some of the alveoli তার ফলে এখানে ভেন্টিলেশন হচ্ছে না. তাহলে when this is your blood vessel, it is your blood vessel for the perfusion, then what will happen? Any gaseous perfusion will happen? No, in this case হবে না, এক্ষেত্রে হবে, ছোট হলেও এক্ষেত্রে হবে. So that is our important. So in this case this is known as physiological, নামটা বলছে physiological because is a physiological unit-এর মধ্যে এটা হচ্ছে, that is not within the proper anatomical dead space. But this, remember one important point, whenever you are dealing with the dead space means gaseous exchange is zero. Whenever and wherever it is gaseous exchange does not take place, that is a dead space. রাইট। সো নর্মালি আমার তো ডেড স্পেস কত হবে? কত হবে? এনি আইডিয়া? কি নর্মালি যেটা বলা হয় সেটা হচ্ছে 3 ml পার কেজি অ্যাডাল্টের ক্ষেত্রে, 3 ml পার কেজি। মেনলি অ্যানাটমিক্যাল ডেড স্পেস আই এম ডিলিং উইথ। নর্মালি এটা আমার আছে। আমার টাইটাল ভলিউম কত? 500 ml। সো 500 মাইনাস 150 কত হলো? হ্যাঁ 300। 350 ml is for adequate for the gaseous exchange। এই ফান্ডাটা দরকার, বুঝতে পারছিস? তাহলে 150 ml is the dead space, 3 ml per kg is a formula, is a rough formula. Suppose a patient having কি বলবো 60 kg, তো 60 kg হলে 180 ml হয়ে যাচ্ছে তার dead space, সেইভাবেই হবে। But average it is 150 ml. You can go with the 150 ml as a dead space. So 500 minus 150 is basically 350 ml is a gaseous exchange is going on, and that is important, and that is called alveolar ventilation. So pulmonary ventilation and alveolar ventilation is not same. Pulmonary ventilation means এখানে anatomical dead space টাও চলে আসবে। So pulmonary ventilation and alveolar ventilation is different. Ventilation and oxygenation is the different. বোঝা যাচ্ছে কি বলছি? ভেন্টিলেশন মানেই অক্সিজেনেশন তা নয়। ভেন্টিলেশন and oxygenation is the different. Pulmonary ventilation and alveolar ventilation is different. So when you are dealing with dead space, so you have to calculate what is happening 350 ml. Now, what is the formula of minute volume? কি কত? minute volume formula কত? কি কতটা যাচ্ছে? হ্যাঁ tidal volume into respiratory rate. But it is the pulmonary ventilations because we are taking tidal volume 500. So 500 into respiratory rate কত ধরি? 12 12 পি ধরি, 12 কত হলো? ml, তাই তো ঠিক করলাম? 5 বড় 60, হ্যাঁ অঙ্কটা ভুলে গেছি। সো 6000 ml 6 লিটার্স হচ্ছে আমার মাইনিউট ভলিউম ইজ কল, বাট দিস ইজ কল্ড পালমোনারি ভেন্টিলেশন। উই আর ডিলিং উইথ মেনলি ইম্পর্টেন্স, আমাদের ইম্পর্টেন্স কি আছে? অ্যালভিওলার ভেন্টিলেশন, যেটা এক্সচেঞ্জ করছে। হোয়াট আর দোজ? এখানে জিনিসটাকে ভাগ করে এটাকে আলটিমেটলি 350 করে দেবো, তাহলে কত আসছে? 5 বছর 60 শূন্য হতে হলো 1, কত হচ্ছে রে? 36 37 নাকি? হ্যাঁ কত হচ্ছে? 42 নাকি? হ্যাঁ হ্যাঁ 4200, চলো 4200 ml, দ্যাট ইজ কি হচ্ছে আমার? অ্যালভিওলার ভেন্টিলেশন, রাইট? প্রত্যেকটা জিনিস তোরা খেয়াল করে রাখ, মনে রাখ, একটু মনে রাখ। তাহলে 4200 ml, it is a ml that is ultimately go for the ventilation and perfusion, ventilation as well as perfusion, and that is why it is called ventilation perfusion ratio. That is why it is called ventilation perfusion ratio. এইখানেতে এই পর্যন্ত এটাকে থামি, কারণ এত লিঙ্ক আপ আছে, আমি যদি সব হুড় করে পড়তে কিছু বুঝতে পারবি না, এতটা একটা make it easy by your own. তাহলে up to this, what concept you have in your mind? That is a compliance is delta V by delta P. It is a change of unit change of pressure causing the unit change of volume. Emphysema, bronchiectasis, bronchial asthma, or reactive airway disease, chronic bronchitis is an obstructive part, there is a difficulty in air out, and restrictive, that is oasis, any pulmonary fibrosis, any pneumoconiosis, silicosis, asbestosis, anything, any osis is a restrictive part, difficulty difficulty in নিতে পারবে না। ডিফারেন্স কি করে বুঝবো, কি করে মনে রাখবো? একটা ওল্ড সক্স এমফাইসিমা, কি হবে? কমপ্লায়েন্স বাড়বে, ইলাস্টিসিটি কমবে, ফিনিশ। রেস্ট্রিকটিভ কজ আমার সিঙ্কড সক্স, দ্যাট ইজ it cannot expand but it can recoil very easily. What does it mean? Does it mean that the compliance is less, elasticity will be more, and that is why compliance elasticity is inversely proportional as well as compliance is inversely proportional to surface tension, and surface tension formula is P. 2T equal to P. What do you mean by P? Huh? P? Excess P? No, that is called the collapsing pressure. That is called collapsing pressure. কেন এটাকে বলছে collapsing? এখানে অ্যালভিওলার, এখানে তোরা জানিস যে এখানে সারফেস টেনশন কাজ করে। কিভাবে কাজ করে আমি বলেছি, কি বলেছি? এয়ার ওয়াটার ইন্টারফেস, এয়ার ওয়াটার ইন্টারফেস ছাড়া নেভার পসিবল সারফেস টেনশন। তো সারফেস টেনশন অলওয়েজ ওয়ান্ট কি? সে নিজের দিকে টেনে নিয়ে আসবে, দ্যাট মিনস ইট উইল কোলাপসেবল। তা তো হয় না, সেটা কি আমার তো হচ্ছে না, বাট অলওয়েজ টেন্ডেন্সি ইজ দ্যাট টু কোলাপস, দ্যাট মিন কোলাপসিং প্রেশার। That collapsing pressure is equal to 2T by I, R. R means what? Smaller. Small R means radius. T means tension, surface tension, and that is called Laplace law. Right? That is come from the Laplace law. You know already. Now, what is the flow? What is the flow? Flow of air is equal to pressure by রেজিস্ট্যান্স। মাথাতে রাখতে হবে সব এগুলো, কিচ্ছু করার নেই। অ্যান্ড রেজিস্ট্যান্স রেডিয়াস। এইগুলোকে পর পর বাড়িতে গিয়ে সাজাবি, একটা একটা করে ডিজিজ বলবি, ধরে ধরে একটা একটা করে হয়ে যাবে। ইটস ভেরি ইজি। নাও আই এম গোয়িং টু অ্যান্সার ইউ হোয়াই ইট ইজ কল্ড bronchial asthma, not bronchiolar asthma. You can ask any clinicians, why sir এটাকে কেন bronchial asthma বলে, কেন bronchial বলে না? Now this is the lungs. This lungs means there are several branches are there, and then alveoli. Okay, now these are the bronchioles, and these up the bronchus, main bronchus, right left gible bronchus, and then up to here, this is called bronchiole. Now radius of the bronchiole, can I see? These are the bronchus and these are the bronchioles. তাহলে কি? bronchiole radius কম। If radius is less, then resistance will be high. If resistance is high, then flow will be low. তাই তো? এখানে কোনো কনফিউশন নেই, কিন্তু ঠিক উল্টোটাই হয়। কেন হবে? তাহলে bronchiole কথাটা কেন বলবো? Means whenever you are taking a radius of bronchiole, it's not a single bronchiole. You have to take overall bronchiole. That radius is more than the bronchus. That is why it is called bronchial asthma, not bronchiolar asthma. Okay, so not a single bronchiole is important for me, just like single bronchus. I am concentrated and I am working on this all together. Whenever it's together, then the radius of the whole bronchiole will be much more higher than this bronchus. Then if the radius is increased, then resistance will decrease. If it is decreased, then that is increase. And that is why flow is outflow, expiratory flow is increased in any COPD patient. তাই তো আমি বলছিলাম না, এমনি করে নিল, এমনি করে নিল, অনেকক্ষণ ধরে নিচ্ছে। Expiration is long because it is a out problem. That is a flow. Flow have to increase, and that's why COPD patients up to which oxygen যদি আমি COPD patientকে বেশি করে দিয়ে দিই, and that patient may die because of drive. So drive is important for wash out of carbon dioxide. A wash out of carbon dioxide and absorption of oxygen, it is a ventilation and perfusion. ঠিক আছে, একটু বুঝতে পারছি ব্রেনের ওপর চাপ পড়ছে, ইট ইজ ভেরি কমন, খুব চাপ পড়াটা খুব স্বাভাবিক, কোনো অ্যাবনর্মাল এটা নয়। সেই জন্য আমি গোয়িং ভেরি স্লো অ্যান্ড গোয়িং সাম এক্সাম্পলস সো দ্যাট ইট ক্যান বি রিমেম্বার্ড all throughout your life. So up to this, what is happening? I am doing that the compliance. Main thing is the compliance and extensibility of the lung. Compliance means such diseases we have to explain that is a restrictive disease as well as obstructive pulmonary disease or obstructive disease of lung. Whenever we are dealing with obstructive, then compliance will be much more. Whenever restrictive, then compliance will be less. Elasticity will be just reverse. And our surface tension, এই যে surface tensionটা যদি আমার বেড়ে যায় তাহলে collapsing pressure will increase. তাহলে কমাচ্ছে কে? সারফেক্টেন্ট কোত্থেকে বেরোয়? টাইপ 2। তো দাদাদিরা কিচ্ছু বলতে পারেনি। Pneumocyte 97% with normal alveolar epithelium, type 1. Only 3% in the each alveolus having the pneumocyte type 2 and it can secrete the surfactant. Already I explained what is the role of surfactant. তাও একবার বলে দিই যখন ইচ্ছা করছে। It is a water phase, right? These are the water molecules, and this is the air, right? So each and every molecules is going একে টানছে, একে টানছে, but there is no any upward force, always it is downward force. এইদিকে কি আছে না, লুমেন, এই যে ঠিক এরকম, হ্যাঁ। So this is happening what? This is going down and so that this is going down and down, collapsing pressure have to decrease so that it can be extend and collapsibility will be diminished by what? Surfactant. কি আছে? Phospholipid, you know already. Phospholipid means some lipids part and some protein part are there like that like এখানে একটা বলের মতো, and then these are happening. Whenever this inserted over here, this is a surfactant inserted here, then upward force will come. For this surfactant, and that's why opposite হয়ে যাবে, তখন এই দিকে ফোর্স আসবে for the distance. এটা আমার চাই। যদি এটা আমার তো না হতো তাহলে এতক্ষণ হাঁপাতাম। So that is helpful for the our surfactant, and surfactant is reduce this one so that collapsing pressure must be reduced so that this is not collapsible. But in case of newborn দুটো প্রবলেম। এক হচ্ছে যে অ্যালভিওলাই গুলো ভালো করে তৈরি হয়নি, সেকেন্ড হচ্ছে সারফেক্টেন্ট আমার অ্যাবসেন্স আছে, then there will be not happen. That is collapsibility will be high and work of breathing will be high, and so the respiratory distress syndrome will appear. I have saved many patients by giving only the surfactant by the proper way, with the proper technique, with some skills. This is very much important. If you understand the patients having some respiratory distress problem, just do a X-ray and it is obvious that patients having problems of surfactant deficiency, available at the market, intubate the baby, and then surfactant allowed, 2 to 3 settings with the different posture, and then surfactant will appear in this hair. When surfactant appear is there, then this force upward will come. আমি যখন সারফেক্টেন্ট দিই তখন আমার এই ছবিগুলো মনে আসে। So that is important, that এটাকে মনে রাখতে হয় না আমার। সেই যে মনে আছে যে এটা দিলাম মানে এটা এইভাবে হবে, টানবে, এটাকে ফোলাবে, বাট our target is that, and it is beautiful result after going some mechanical ventilation or CPAP, giving for 1 day ki half an hour is extensively very good result. At least in my case 100% result successful. So surfactant is very much important. Surfactant is very important. How it works, compositions written in your book. Always remember that whether patients having surfactants adequate or not, one ratio is taken, that is the lecithin sphingomyelin ratio. I am not going details, probably it is written in your book. So this type of explanations, you have to always think what is happening. Now during the compliance, again we come to the two types of compliance are there. One is dynamic compliance, another is static compliance. Another is dynamic, another is static compliance. So this chapter is physics oriented. Number one, regular practice and reading with good books is essential. Every lectures you have to repeat it to listen every each and points. That's like for today's message was that is a obstructive out problem, restrictive in problem. Ventilation and oxygen is different. Compliance is inversely proportional to the elasticity. Compliance is inversely proportional to the surface tension. Now, what does this mean? Don't make it complicated. Dynamic means যখন মুভিং এয়ার আছে, এয়ার যখন মুভ করছে তখন ডাইনামিক, তখনকার যা কমপ্লায়েন্স that is called dynamic. And static, there is no air movement, that is called static. বোঝা যাচ্ছে? So that is important. Now another important point is that in case of static, মানে আমার কি হলো না, এয়ারটা যাচ্ছে না, কোথায় যাচ্ছে না? অ্যালভিওলারে. That means alveolar pathology, simply only alveolar pathology will show static compliance. But in case of dynamic, some airways come into play. Because you have to move. You have to move means some airways must be there. So there must be a component of airways as well as alveoli in case of dynamic. তাহলে এইবার এটা কেন বললাম কারণ to diagnose the diseases. You came across with the pneumonia, you came across with the pulmonary edema, you came across with the COPD, asthma, bronchiectasis, everything. What kind of is that? Suppose a patient with pneumonia. এখন খুব bacterial pneumonia পাচ্ছি. So suddenly we are getting some bad pneumonia with the consolidations. So if pneumonia patients means the static compliance is compromised. Now compliance formulaটা কি? C equal to কত? Delta V by delta P. Now this V is final, V is fixed. Now this in case of dynamic compliance, the delta V by pressure change of what? Pressure change of what? Any idea? Pressure change of PIP minus PWP. Just মনে রাখ ফুল ফর্ম গুলো বলছি আমি. So if we take a breath, suppose in this way, এখান থেকে কি একটা breath দিলাম, then it will come down like that. This is called PIP, and this level is PWP, and this is also PWPP. That means what? Peak inspiratory to pressure. Peak inspiratory pressure. This is inspiration. What is that is mean? Peak end expiratory. Simple. End expiratory is the pressure. So this minus this is a pressure change in case of dynamic compliance. কোশ্চেনটা এই জন্য করলাম বা এটা বলার উদ্দেশ্য এটাই, যদি আমার কোনো পেশেন্টের অ্যাজমা থাকে, if any patients having bronchial asthma or reactive airway diseases, then এই জায়গাটা চেঞ্জ করতে হবে. এই জায়গাটা চেঞ্জ করলে আমি কমপ্লায়েন্সকে বাড়াতেও পারবো, কমাতেও পারবো. জাস্ট ফর্মুলাটা আজকে লিখে নে। অ্যান্ড দেন স্ট্যাটিক কমপ্লায়েন্স ইজ ফিক্সড, দ্যাট ইজ প্ল্যাটু প্রেশার, প্ল্যাটু PLATUE, প্ল্যাটু প্রেশার মাইনাস পি, প্ল্যাটু প্রেশার মাইনাস পি। সিগনিফিকেন্স কি স্যার? আমি কমপ্লায়েন্স জানলেই তো হলো, এত ডাইনামিক আর স্ট্যাটিক জেনে আমার কি হবে? একদম ঠিক, জানার এই জন্য তো দরকার, এসেন্সিয়াল। If you want to treat properly, then this is important for your, if you want to put on ventilator on your subject or patients, this must be known. তো যদি যে কোনো আইসিইউতে যাবি দেখবি এই সবগুলো লেখা আছে, পি পি। সো হোয়াট ইজ কামিং অন, হোয়াট ইজ কামিং অন? এন্ড এক্সপিরেটরি প্রেশার, আমার এন্ড এক্সপিরেশনের সময় যে প্রেশার সেটা এটা, সেখান থেকে তুললাম এখানে। So that can be 30, 20, that can be. আমার পেশেন্ট ফুলছে না, এক্সপ্যান্ড করতে পারছে না, আমি পিপ বাড়াবো, পিপ বাড়াবো মানে পিআইপি বাড়াবো, পিআইপি বাড়াবো, যাতে আমার এয়ারটা ভালো করে ঢোকে, কমপ্লায়েন্স স্টেরিলিটি হয়। So we can explain in all the details, but I am also some kind of drowsiness coming on, and you're also feeling bored like that. What is happening, sir? Ki bolche compliance bollo, tade thik chilo. Then again and he is telling the dynamic, and bola uddeshyo ektai, the static compliance means alveolar pathology, and dynamic compliance is pathology of both airways or alveoli, or alveoli plus airways, বা only airways, but static always alveolar pathology. Alveolar pathology means pneumonia, some pulmonary edema, some sorts of mucus plug inside the alveolar duct, so that it can compromise the ventilation. And again I am telling you, ventilation and oxygenation is different. Ventilation and oxygenation is the difference. Keno? Karon ventilation means ekhane jodi ekta লাইন hoy, এইখানে এয়ার এন্ট্রি হবে প্লাস আউটসাইড বেরোবে with the exchange of gaseous exchange, it is called ventilation. তাহলে অক্সিজেন ঢুকলো, এক্সচেঞ্জ হলো, কার্বন ডাইঅক্সাইড বেরোলো, this process is called ventilation. But oxygenation is only adding up oxygen. এই জায়গাটা ভুল করে সবাই, অনেকেই, আমরাও করে এসেছি অনেকদিন, যে পেশেন্টের শ্বাসকষ্ট হচ্ছে, আচ্ছা করে অক্সিজেন দে, did not showing any about the carbon dioxide level. তাহলে কার্বন ডাইঅক্সাইড যদি ওয়াশ আউট না হয়, আমি যতই কার্বন ডাইঅক্সাইড দিই না কেন, পেশেন্ট ফুটে যাবে অনেক পরে। কেন? it will decrease the drive of respiration, will decrease the drive of breathing, work of breathing কমে যাবে, আলতে আলতে বাচ্চা ঝিমিয়ে গেল। আমাদের জুনিয়র এরকম অনেক সময় আমাদের বলে, স্যার আমি তো অক্সিজেন দিচ্ছিলাম, আমার স্যাচুরেশন তো আমার মেনটেন করছো, তাও কি করে মরে গেল। বাট he forget about the arterial blood gas analysis. If the intern or any our juniors is do the initially the carbon dioxide level suppose 70 millimeter of Hg, and remember, if it is 40 is normal and it is 70 is there, that is always you are remember each 10 millimeter of carbon dioxide increase means 0.1 pH will be less. Suppose 40 থেকে 70 হয়েছে, সাপোজ 40 থেকে 70 হয়েছে, মানে কত মিলিমিটার আমার বেড়েছে? 30। প্রত্যেকটা 10 এর জন্য 0.1 করে পিএইচ কমেছে। নরমাল পিএইচ কত? 7.4। তাহলে করে 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 আলটিমেটলি যখন 70 তখন তার 7.1 সিভিয়ার রেসপিরেটরি or metabolic acidosis. And it is happened, it is drive with less cardiac shock and cardiac death, instant death with respiratory failure. So the patient must have ventilator, and so I/E ratio must be কি করতে হবে? E এর পরিমাণ বাড়িয়ে দিতে হবে 1:3, 1:4 এরকম, যাতে কার্বন ডাইঅক্সাইড ওয়াশ আউট হয়। So carbon dioxide retention is much more dangerous than the oxygenless. Remember that. Up to this, I am closing my lectures. Any questions? Any type of questions you can ask me, because these things are important and it is a one-on-one lecture. It cannot be repeated at all, and it will be very much helpful whenever you are going to the words. যখন তোরা ওয়ার্ডে যাবি তখন এগুলো কাজে লাগাতে হবে, নইলে কিচ্ছু শিখবি না, স্টেথো দিয়েও কিচ্ছু বুঝবি না। So that's why expiratory more is obstructive, inspiratory যাচ্ছেই না, restrictive. So whenever you are doing so, do a spirometry. I am not going details to spirometry is a different classes will be there. Anyhow, you have to take home message on that. The compliance is very much important for our extensibility, stretchability of the lung, and that is the two types, that is the dynamic and static. Static is for only alveolar pathology, and dynamic is for the airways as well as alveoli. And surface tension, elasticity is inversely proportional to the compliance, right? Ventilation and oxygenation is not same. Ventilation is like the oxygen is going in, carbon dioxide out after the gaseous exchange. That is called ventilation proper. Next class we will try to explain the ventilation and perfusion. What is happening on, what is the mismatch, what is going on, what is the compensatory mechanism of that. Everything I will try to explain in my lucid language. Thank you very much.
So today's topic is acid-base balance. Now, acid-base balance. Do we know about this? What is acid, what is base? The simple Arrhenius theory says whatever in solution provides H plus ion is called acid, whatever provides hydroxyl ion is base, and compounds that produce salt with acid and whose solution is having pH more than 7, they are called alkali. Means the bases which are water soluble are simply called alkali. So when we say acid base balance, does it stand all right for our body? Is it a misnomer? Yes. Our body is full of water, so it should be acid alkali balance. Right. So the bases which are not water soluble, we do not comply with those. Fine. Now, which resist change in pH, right? So whenever an acid influx occurs in our body, the buffers should come in action first. So there is a 3-level defense against any change in acid base balance. How do you know whether a compound, whether a solution is acidic or basic? By a term called pH. What is pH? Negative logarithm of hydrogen concentration. So more hydrogen concentration, less the number. So pH 4 is more acidic than pH 6. Correct? More than 7 is not acidic at all. It is alkaline. It is alkaline. Clear? Now, do we know about this equation? কি নাম ইকুয়েশনটার? এটা আমি এটা ছোট্ট করে বলি, স্মল থিং. Today's topic is very, very important. Definitely you will get one long as well as one short, even a clinical correlation question. Must. So Henderson-Hasselbalch equation says about 4 parameters: pH, pK, concentration of base, concentration of acid. Now, there are different forms of writing this equation. Some people write conjugate base by acid, or base by acid. So, whatever it is, there are 4 parameters. So, in an equation where there are 4 variables, if 3 are given, can we deduct the 4th one? Yes or no? So, remember, in any equation regarding this acid base, 3 of these will be given to you, and 4th one you have to find out. 4th one you have to find out. Okay? 3 of these will be given to you. Even in the instruments what we have invented so far, they are capable of measuring any 3 of these parameters. The 4th one, the instrument will calculate with AI, the normal formula. This formula is fed into that, and according to that it will calculate and give. Previously what we used to calculate, now the machine does the calculation for us. Clear? Now, we must remember this slide. We must by heart this slide. The question is, what are body buffers? What are body buffers? Just write it down. This is so important. Write it down, memorize it once and forever, so that next time there are so many points to discuss only in this. There is a sequence 1, 2, 3, 1, 2, 3. This is based on their relative importance. There are 3 segments. One is ICF, another is ECF, another is RBC. Correct? Why RBC is different? Because RBC contain a unique protein which no other tissue contains, that is hemoglobin. Clear? So, RBC maximal buffering activity is done by hemoglobin. See the salt Ka plus. Why K plus? Can anyone tell me? Why not Na plus? Whereas here this Na plus. Anyone? Why there is K plus here, but here is Na plus? Yes, outside the cell. This is ECF, this is outside the cell. The sodium content is high. In ICF, potassium content is high. So, whenever we prepare a buffer for ECF enzymes, we should use sodium buffer, sodium salt. Whenever we are preparing a buffer for intracellular enzymes, we must prepare with the same salt but with potassium. Clear? This is one point you get from here. Correct? What is another point? The sequence of their importance. In ECF, the highest importance is given to bicarbonate buffer. Next comes phosphate buffer, and last comes albumin, the most abundant serum protein among all the proteins. সবচেয়ে বেশি থাকে albumin. তাই albumin being a protein, it can donate H plus ion, correct? So it can act as an acid. In ICF, the phosphate becomes most important, and bicarbonate comes last. This is also ICF, RBC. Here also bicarbonate comes last. Second comes protein here, and in this case second comes phosphate. So they just exchange their place. In ICF and RBC, the first two, they just exchange their position. Correct? Can you all remember? Fine. Now, we will see this equation. When we say how does bicarbonate buffer act or function, we must deduce this equation. So, according to this equation, pH should be pH is equal to pKa. What is Ka, pKa or Ka? Dissociation Ka means dissociation constant for the acid. What type of acid we are talking about? Weak acids, correct? So, the conjugate base is stronger than the weak acid. Our +2 knowledge says that. So, what is the conjugate base here? Bicarbonate. What is the acid here? H2CO3 or carbonic acid. Now, if we calculate this equation for bicarbonate buffer, we will get a value, and that is very important. Remember, a buffer is most active when this ratio is unity, means 1, or near 1, means 0.9 or 1.01, like this. Clear? Fine? So, in our body, buffer should be very active. That should be there, otherwise there is no use of keeping buffer. But here, we will see that pKa for bicarbonate, carbonic acid is 6.1, 7.4 is the normal blood pH. So, we write 7.4. Then pKa is given in the chart. Which chart? In chemistry book. pKa for carbonic acid, it comes 6.1. Fine? And then this one we calculate, or this one we calculate. One of them we will get from the instrument. Which one? Either of these. Some instrument measure this one, some instrument measure this one. Mostly they measure this one. Fine? Now, since 7.4 is given, if these two are given, 6.1, and these two are also given, then we get log 20. Log 20. What is the, if you divide this, how much it will be? 20:1. 20:1. That means the concentration of base is 20 times that of the concentration of acid. So, how come the nature failed to produce a more efficient buffer? The question may arise, why this excess alkali? So, they termed this excess alkali as alkali reserve. They term this excess alkali as alkali reserve. Correct? Fine. So, from this alkali reserve, what we get? Suppose suddenly we ingest large amount of pickle, achar. So, the pickle introduces organic acid into our bloodstream. So, our blood pH suddenly falls, correct? And there is no time to correct it or rectify it by other mechanisms. What is the first line of defense? Body buffers. So, this excess alkali will come into action. We will go for compensation with the ingested acid, so that our body gets some time to cope up with the change in the pH. To cope up with the time in the pH. Which one is more harmful? Acidosis or alkalosis? Acidosis. So, our body must resist acidosis. That is why we have alkali reserve, not acid reserve. Acidosis is more harmful than alkalosis. That is why our body has alkali reserve, but not acid reserve. Clear? So, this alkali reserve is for emergency purposes. Immediate first line of defense against change in acid concentration inside the body. Okay? The next part comes the calculation for phosphate. The phosphate is phosphoric acid. It has 3 dissociable hydrogen ion. First one, if we dissociate, then its pK is 1.96, second one is 6.8, and third one is 12.4. It is almost impossible to remove the third dissociable hydrogen from phosphoric group. So, all reactions come up to this level. That is why we have Na2HPO4 and NaH2PO4. That means, in this case, the base will be Na2HPO4. Equation A, base will be Na2HPO4 and acid will be NaH2PO4. The third hydrogen is not possible to dissociate. pH will be 7.4 and pK will be 6.8. This 6.8 you have to remember. 6.1, 6.8 you have to remember. Okay? This you have to memorize. And then if we put all the values, we will get the ratio. Here what we got? 20:1. There we will get 4:1. We will get 4:1. That means again alkali reserve. Clear? So, now you know about the body buffers and you know about 2 buffers which are more important. In RBC, it is mostly hemoglobin buffer and it requires histidine because it contains histidine residue. So, the histidine has got pK around 6.1. Okay. So, it can act as buffer. Now, this shows the relative weightage of these buffers as their activity. Which one is highest? Intercellular buffering, proteins, then bicarbonate is most in ECF, then comes phosphate, then comes protein. Right? So, maximum buffering activity is done by bicarbonate in ECF. ICF you forget for the time being. For ECF only you remember. Whatever calculation we do on ECF. When we go for ABG analysis, means arterial blood gas analysis, then we go for blood pH estimation, blood bicarbonate estimation, blood PCO2 estimation. CO2 is a gas, H2CO3 we cannot measure. H2CO3 we cannot measure, we can measure only bicarbonate. But H2CO3 we measure in the form of partial pressure of carbon dioxide. That is why if you go through any ABG analysis report, you will find PCO2 in something mmHg. Like any gas, partial pressure, mmHg will be the unit. And in this case, it will be millimoles or milligram per deciliter. Fine. Now, next comes respiratory. When any change occurs in the blood pH, the first line of defense is body buffers. When body buffer fails to rectify it, say in a condition of diabetic ketoacidosis, that means huge amount of ketone body has been produced in the body and it is accumulating in the blood, unused ketone body, and it is causing ketoacidosis. Fine. Our body buffers are unable to cope up with this huge amount of ketone body. So the next defense action comes from lungs, respiratory, and third one comes from the renal or kidney. So we have three defense mechanisms. First one is from body buffers, second one from lungs, third one from kidney. Now lungs or respiratory mechanism is immediate but short-lived. Renal mechanism is slow to begin but provides permanent solution. কি বললাম? বডি বাফার্স হচ্ছে ফার্স্ট লাইন, প্রথম বিরোধ। সেকেন্ড হচ্ছে লাংস, হুইচ অ্যাক্টস ইমিডিয়েটলি বাট শর্ট লিভ, অল্প সময়ের জন্য থাকে। ঠিক আছে? যদি প্রলং কন্ডিশন পারসিস্ট করে অ্যাসিডোসিস, in that case kidney will come into action and that will provide, it will slow to begin, slow to start, but it will provide permanent solution. And what is the solution? What is the goal here we want to achieve? We want to achieve a fully compensated state. Now when you say acidosis, so 7.4 pH will go down to 7.15, suppose. That is uncompensated. Right? Now the defense mechanism is working and the pH is again pulled up to 7.4. That is compensated. Now the values will change in that particular equation. Why? Because it's a ratio. Remember, it is not a pure number. It is not a pure number. Suppose 20:1, that ratio you want to bring. Then it could be 20:1, it could be 40:2, it could be 60:3. All value will be 20:1. But are they same? No. Correct? So remember, it functions over the ratio, not the exact value. So the exact values will change. And seeing those exact values, we can make out whether this condition is uncompensated, compensated, or partially compensated. Three conditions. In acidosis alkalosis, we have three conditions: uncompensated, partially compensated, fully compensated. In uncompensated, pH is altered. In partially compensated, pH is altered. In fully compensated, pH is normal, but the alkali reserve will be reduced. Why? Because it has been used by the excess of acid. Or PCO2 will increase because it has to produce more alkali. Correct? So values will change, but ratio will remain same. To keep that, because nothing we can change in this equation. See, can we change the pH? No, it should be 7.4. Can we change the pKa? No. Can we change the log? No. Then what we can change? The values of these two. Correct? And if the ratio changes, then it will never be 7.4. Whatever it may be, the value, it must come 1.3 to make it 7.4. Clear? So values will change. Bicarbonate may go low, CO2 may go high, values will remain, ratio will remain normal, same. Correct? Now we will perform a small experiment with two of you volunteers. 3, start. আরো জোরে, আরো জোরে, আরো জোরে। ঠিক আছে, কতক্ষণ হলো? শরীর খারাপ লাগছে? হয়েছে? ব্যাস, স্টপ। ও ঠিক করে করেনি, হি ডিডন্ট পারফর্ম ওয়েল, হি পারফর্ম ওয়েল। কি মনে হচ্ছে? মাথা ঘোরাচ্ছে? হ্যাঁ, শরীরটা খারাপ লাগছে তো একটু? নাও টেল মি, what are these two conditions? For him, I asked him to wash off the air from the lungs, but he did it wrong. যত নিবি তার থেকে বেশি ছাড়তে হবে, ঠিক আছে? একটু প্রথম দিকে হয়েছে, তারপর পরের দিকে ওটাকে জোরে নিঃশ্বাস নিচ্ছিলিস, ঠিক আছে? ওয়াশিং অফ কার্বন ডাইঅক্সাইড আর রিটেনশন অফ কার্বন ডাইঅক্সাইড, বলো কোনটা কি কন্ডিশন? ক্যান এনিওয়ান টেল মি? হ্যাঁ, অ্যাসিডোসিস অ্যান্ড অ্যালকালোসিস। ওয়াশিং অফ CO2 মানে conditions which will promote short breathing will cause and conditions which will promote slow respiration will promote acidosis. Means inhibition of respiratory center, excitation of respiratory center, alkalosis. Now there are different drugs. If I choke him to the throat, what will happen? Acidosis, correct? And for him, he should have been fainted by this time, because he should, after some time, he won't be in his consciousness, and automatically the breathing will slow down. Okay, so this type of breathing, where the breathing will show a graph like this, up and down, we call it as, anyone, Kushmal breathing. Kushmal breathing. Okay, fine. So retention of CO2 and flushing of CO2, both are detrimental. So when we say retention of CO2, what happens? The CO2 accumulates and it forms H2CO3. It is broken into bicarbonate, correct? So suddenly which will increase? H2CO3 will increase, correct? Which part? The base, the lower part, the denominator. This part will increase. So the ratio will less. So it won't be 1.3 anymore. It will be less than 1.3. So what will happen? pH will be less than 7.4. Clear? In this case, there is no CO2. Only bicarbonate is there. What will happen? The ratio will increase from 20:1 to higher. So what will happen? This will become more than 1.3, and this won't be any more. It will be 7.6, 7.7. Beyond that, you will die. Do not try. Thank you for your cooperation. Fine. So now we know that the components, there are two components. There are two components. One is base, another is acid. With this experiment, we have come to this conclusion that the acid component is regulated by lungs. So we call this acid component as respiratory component. Respiratory component. That's all. I mean, যেটুকুন বলছি এইটুকুনি বুঝলে যথেষ্ট. This is the basics of acid base. এর উপরে পুরো চ্যাপ্টার দাঁড়িয়ে আছে মেডিসিনে। Okay, so respiratory component is H2CO3 and upper component is left with what? Renal. আমরা তো একটাই বাকি আছে আর, সেটা কোনটা? বাফারে কি, বডি বাফার কি করে? বডি বাফার এইটা রিনেট করে, তাই না? বাফার উপরে কোনটা ডিপেন্ড করে? পিকে, ফার্স্ট লাইন অফ ডিফেন্স, সেকেন্ড লাইন অফ ডিফেন্স H2CO3. আমি বললাম H2CO3 আমরা মাপতে পারি না। We cannot measure any acid. Remember, we cannot measure any acid. We can measure their ratio. So instead of H2CO3, we measure PCO2. And the unit changes to a normal কত? বাইকার্বনেট নরমাল কত? ঠোঁটস্থ থাকতে হবে, মুখস্থ, বলা যাবে না। In this life, from now on, you cannot afford to forget this. You cannot afford. Because 90% of diseases where surgical intervention is not required, they present with either acidosis or alkalosis. Okay? So just remember. Fine? Now we move on to the next slide. So by this time now we have come to know that the bicarbonate is called renal component, H2CO3 is called respiratory component. The next part is what happens and how CO2 is actually released by RBC. So this is an RBC which shows its location where? Tissue. The location of RBC in tissue, and it shows কি লেখা আছে? Chloride shift. So chloride shift occurs in tissue. What is the opposite location? RBC in lungs. What is the function of RBC? Carry oxygen from lungs to tissue and bring CO2 from tissue to lungs. So in the tissue, it will absorb CO2. How? With the help of hemoglobin and one enzyme called carbonic anhydrase, whose concentration is much higher than the plasma inside the RBC. Correct? What H2 carbonic anhydrase will do? Carbonic anhydrase will dissolve CO2 into H2CO3. The H2CO3 will dissociate and give away this H plus ion to whom? What is this imidazole ring of what? Histidine residue of hemoglobin. So the hemoglobin will take the H plus ion and will become HHB. Now as a matter of fact, the acidified or HHB hemoglobin loses its affinity towards oxygen. So it will release oxygen and oxygen will go to cell. So actually entry of CO2 will promote release of oxygen at tissue level in hemoglobin. But problem arises with this bicarbonate. Correct? This bicarbonate is required for other tissue also. Which tissue? ECF. So bicarbonate will go to ECF. Problem is, if the bicarbonate doesn't leave RBC, then H plus ion will again combine with this. Instead of combining with histidine. Why? Histidine is a Lewis base. Bicarbonate is an Arrhenius base. Which one is stronger? So, in order to make H plus ion associated with hemoglobin, we need to remove bicarbonate. But problem is, if we remove bicarbonate, then RBC will be positively charged. In order to keep the neutrality of the membrane of RBC, the chloride ion must go inside, so that bicarbonate can come out and chloride can go in. This is called Donan membrane equilibrium. This is an example of Donan membrane equilibrium, where the molecules which can migrate will migrate across the membrane unequally to maintain the neutrality of the membrane, because other molecules, charged molecules, cannot distribute itself equally across the membrane. So, this is called chloride shift. Remember, this occurs in tissue. In lungs, what happens? Lungs, CO2 should come out and O2 should go in. How CO2 will come out? The bicarbonate from the ECF will enter into RBC in exchange with chloride. It's called reverse chloride shift. It's called reverse chloride shift. The same thing will occur in a opposite direction. The bicarbonate will combine with H plus ion to form H2CO3. What is the enzyme? Same enzyme, carbonic anhydrase. Only thing is, pH inside this cell slightly changes, and that will give a signal to carbonic anhydrase in which direction it has to work. Fine. The H2CO3 is then broken into H2O plus CO2. CO2 being gas, it can come out of the RBC easily. The vacancy is filled up by O2 from the alveoli. O2 will enter and it will form with Hb, H plus ion will release. So, HbO2 will form. So, again entry of oxygen here will help in release of CO2. Entry of oxygen will help in release of CO2. Clear? So, these two you remember. This is for chloride shift and reverse chloride shift. Now, renal regulation. Renal regulation mostly function through three processes. Here is given 4. This all these are taken from Vasudevan. Why Vasudevan? Because I got him as my teacher once, luckily. So that's why we have a little tendency to if you know your teacher, you always find his book is good. That is my biasness, you can say. Anyway, that biasness is not so bad. I won't give you any wrong information. Fine. So here, the first point and the fourth point, you read all the points. See, it is needless to say that there are many slides, many classes available in online. What is special, what I can give you class is that the correlation. There are plenty of biochemistry teachers who are more handsome or more good looking than me, who can speak better English, who can speak better Bengali than me, and better Hindi also. Doesn't matter. So, what is special you get from this class? How you correlate. Right? Bakura? Height we achhi on. So, there are 4 ways it can function. Actually, there are 3 ways. The first one and last one occur simultaneously. First one and last one occur simultaneously. I'll show you. The first one is excretion of H plus ion. That means when H plus ion is excess, what kidney will do? Kidney will get rid of H plus ion. Fine. And what is next? If H plus ion is more, kidney will try to retain more bicarbonate to increase the base or alkali ratio. Right? So next point is retention of bicarbonate or reabsorption of bicarbonate. The third point is excretion of titratable acid. What do you mean titratable acid? Now, when I asked him to hold his breath, why do you think he has suffered from acidosis? Due to which acid? Carbonic acid. Now, if I ask him to perform another experiment, that is climbing up to 7-story building 3 times, which acid will accumulate? Lactic acid. So again he will suffer from acidosis, but this time lactic acid. Correct? Now if I don't feed him for 3 days, again he will suffer from acidosis, but this time for ketone bodies. Correct? So 3 different conditions, 3 different acids. Clear? Can there be any other form of? Yes. Xanthuronic aciduria. Where do you find xanthuronic aciduria? Amino acid metabolism disorders. Correct? Huh? Then dicarboxylic aciduria. Correct? So there are different acids. Now these acids are titratable acid. These acids are titratable acid. Can we titrate bicarbonate? These are non-volatile acids. We cannot titrate carbonic acid, can we? We can titrate acetic acid, lactic acid, malonic acid, malic acid, everything, but not carbonic acid. Why? Because that is volatile. So when we say excretion of titratable acid, it is not excretion of CO2. It is excretion of lactic acid, acetic acid, and all other titratable acids through kidney, because now we are talking about renal mechanism. CO2 is maintained by lungs and others by kidneys. Correct? Last one is excretion of NH4 plus or ammonium ion. Now this takes place along with H plus ion. So the urine receives an H plus concentration or positive ion concentration due to H plus ion and ammonium ion, both. H plus ion and ammonium ion. The acidification of urine is mostly due to NH4 plus, not H plus. Acidification of urine is mostly due to NH4 plus. So excretion of NH4 plus means what? Excretion of that same H plus ion will combine with NH and form NH4 plus. So now we will see 3 diagrams. Although there are 4, we will see 3 diagrams, because in 3 diagrams you can explain 4. What is this diagram? Which one? 1, 2, 3, 4, which one? There are 3 compartments. One is plasma or ECF, another is PCT cell, proximal convoluted tubule, and third one is tubular lumen, where the urine is formed. See, the sodium is entering from tubular lumen because it has been filtered freely by the glomerulus. Now it is being reabsorbed. Which hormone will dictate the reabsorption of sodium ion? Bolo? It starts with A. Aldosterone, mineralocorticoids, correct? The retention of sodium ion, fine. So sodium ion is retained in exchange with what? bicarbonate. See, the H plus ion goes out and bicarbonate comes in. ঠিক আছে? এটা হচ্ছে excretion of H plus ion in proximal tubule. Can it be used for retention of bicarbonate? No. Why? Because bicarbonate is not entering from lumen. So this diagram cannot be used for, cannot be clubbed with the second point. This diagram can be clubbed with fourth point. We will see. Second, that is reabsorption of bicarbonate. See, bicarbonate is here. Correct? Sodium is absorbed, bicarbonate is forming H2CO3, CO2. CO2 is entering here into the PCD tubule. Again, it is forming bicarbonate, and this bicarbonate is absorbed. What is the difference between these two pictures? Bicarbonate is not entering from lumen. That's all. Here, the source of bicarbonate is from the carbon dioxide present in the lumen. Clear? So when H plus ion is excess, first is to get rid of H plus ion, you will get rid of. Then the second, what will think that due to excess of H plus ion, the bicarbonate concentration has gone down, so we must retain bicarbonate. So it will retain bicarbonate. Next, excretion of titrable acid. Titrable acid means lactic acid, phosphate, etc., etc. Suppose I am saying, now I am telling lactic acid, acetic acid, all these I am telling, but showing a picture of phosphoric acid. Are you okay with this, or you have any question? है ना? আমি বলছি মুখে বলছি ল্যাকটিক অ্যাসিড, অ্যাসিটিক অ্যাসিড, কিন্তু ছবি দেখালাম ফসফরিক অ্যাসিডের, কেউ কিছু বলি না তো? Ask me, why sir you are showing lactic phosphoric acid instead of lactic acid? বলো কি হতে পারে? আচ্ছা, what is the source of phosphoric acid? From where we get phosphoric acid? phosphoric acid আমরা কোন খাবার থেকে পাই? ফসফেট। আমি বলেছিলাম ক্লাসে একবার, সফট ড্রিঙ্কস ফুল অফ ফসফেট, সফট ড্রিঙ্কস, কোক, পেপসি, থামস আপ, ফান্টা, স্প্রাইট, এটসেট্রা এটসেট্রা এটসেট্রা, full of phosphates. Okay? Now, so phosphate is shown here because the phosphate is most predominant titrable acid. That is why. Instead, you can find lactic acid also. How? The same thing will happen. This Na2HPO4, is it alkali or acid? Alkali? Alkali, Na2HPO4. This splitting into Na plus being reabsorbed due to aldosterone. NaHPO4 is there. This NaHPO4 will combine with H plus ion and form NaH2PO4 and will be excreted. Now just put, instead of NaH2PO4, put lactic acid, lactate. The lactate will combine with H plus ion and will be excreted. The ketone bodies, acid to acetate, will combine with H plus ion and will be excreted. Okay? Or if you take too much of vinegar, acetate, same thing will happen. So titrable acid will be excreted. Fine. Now the fourth one. Now you see. Now I said the first diagram can be clubbed with the fourth diagram. What is special here? A new molecule is come into action. What is this glutamine? Can anyone tell me what is the source of this glutamine? বাঁকুড়া বল, গাড়ি বল, বল কোত্থেকে আসে গ্লুটামিনটা? This glutamine comes from brain. In the brain, ammonia is trapped by glutamate, by the enzyme glutamine synthase. That glutamine is traveled throughout the body to the kidney, and in the kidneys, glutaminase enzyme will again split glutamine to glutamate plus ammonia. This ammonia will be excreted directly as ammonium ion. The NH3 plus, when it will come out to the tubular lumen, it will meet with H plus ion secreted by the first diagram, and it will form NH4 plus. Now, the acidity of the urine is due to two molecules. I said mostly. One is that NH4 plus and H plus ion. How do you know that? How do you measure? By measuring the acidity of the urine using formaldehyde. Using formaldehyde. Why? Because formaldehyde will interact with ammonium ion. So we can measure only H plus ion. And without formaldehyde, we can measure the acidity. The difference will give us the concentration of ammonium ion. Good? Easy? So all four diagrams, first one you can club with the fourth one. Correct? So from এই চারটে বাজে যা আচ্ছা পড়ানো শেষ হয়ে গেছে এই পর্যন্ত একটা সাইড বাকি আছে দেখবি ইম্পর্টেন্ট লিখে নাও এখান থেকে রিভার্স কোশ্চেন আসবে কিরকম কোশ্চেন আসবে either of these conditions will be given in MCQ. What are the conditions factors affecting renal acid excretion? Increased filtered load of bicarbonate. এটা মানে কি? এটা মানে প্যারাডক্সিক অ্যাসিডিউরিয়া। বেশি অ্যালকালি বেরোলে তার সঙ্গে সঙ্গে অ্যাসিড বেরিয়ে আসে। More alkali follows excretion of more acid. একে বলে প্যারাডক্সিক্যাল অ্যাসিডিউরিয়া। মানে হয়েছে অ্যালকালোসিস কিন্তু বেরোচ্ছে অ্যাসিড। একে বলে প্যারাডক্সিক্যাল অ্যাসিডিউরিয়া। গতবার কোশ্চেন এসেছিল। ডিক্রিজ ইন ইসিএফ ভলিউম। যদি ইসিএফ ভলিউম কমে যায়, ডিক্রিজ ইন প্লাজমা পিএইচ মানে অ্যাসিডোসিস মানে টাইট্রেবল অ্যাসিড, হাইপোক্যালিমিয়া আর অ্যালডোস্টেরন সিক্রিশন মানে অ্যালডোস্টেরন বেশি হাইপার সিক্রিশন অফ অ্যালডোস্টেরন। হাইপোক্যালিমিয়া সম্বন্ধে একটু বলে দিই, এই দুটো লাইন এইটা পড়ে রাখো, হ্যাঁ এইটা পড়ে রাখো। When there is increase in H plus ion in the ECF, there may be exchange of H plus ion with K plus ion within the cell. The net effect is apparent increase in ECF potassium level or hyperkalemia. In general, metabolic acidosis is associated with hyperkalemia. So, whenever the ABG analysis is done, it also performs sodium potassium chloride estimation. Same instrument. So we get potassium also. If there is acidosis, we must check whether potassium level is low or not. We must check hypokalemia. Acidosis, acid with hypo. Acidosis, hypo. Acidosis, hypokalemia. Acidosis, hypokalemia. Okay? Huh? Sorry, hyperkalemia. আচ্ছা ঠিক আছে আর লাস্ট হয়ে গেছে কমপ্লিট তাহলে জাস্ট there are 5 things to remember. One is body buffer and their importance by sequence. Next is the equation and the components. Equation for bicarbonate, equation for phosphorus, phosphate, and the components name. Above, renal, below, acid, respiratory component. Renal component, respiratory component. Done. Next comes first line of defense, body buffer, alteration of the pKa. Next comes respiratory component or lungs. It is immediate but short-lived. Next comes renal. It is delayed, means slow to start but provides permanent solution. And then 3 conditions of this acid-base disbalance: uncompensated, partially compensated, fully compensated. Lastly, renal mechanism: excretion of titrable acid, excretion of ammonium ion, and retention of bicarbonate. তিনটে ওই একটা তো ফ্রি। অলরাইট।